Good morning, everyone, and welcome to Grand Rounds. My name is Eddie Citron. I'm one of the internal medicine chief residents, and today I have the pleasure of introducing Dr. Thomas Tolbert. He received his MD from the Albert Einstein College of Medicine in 2014 before completing his residency in internal medicine at Yale New Haven Hospital. He's been a member of the Mount Sinai community since 2017, when he began as a fellow in pulmonary and critical care medicine. He joined the faculty as assistant professor after completing his fellowship in sleep medicine in 2021. As a physician scientist at the beginning of his career, Dr. Tolbert hopes to develop expertise in the influence of cardiopulmonary comorbidities on the pathophysiology of sleep apnea. Please join me in welcoming Dr. Tolbert to Grand Rounds.
All right, thank you very much. Thanks for inviting me, Dr. Thomas, to the chief residence. Causal uncertainties in obstructive sleep apnea, any room to breathe. That's the clever title of my talk. I have, let's see if this works. No disclosures. Okay, there we go. So causality, cause and effect. In my time between medical school, residency, fellowship, giving chalk talks, giving talks like this one, now as an attending, I have drawn a fair number of variables on boards and arrows between them, with the implication that I'm saying A causes B. Or to be more precise, A has a causal effect on B. But admittedly, I'd never thought very hard about what that means, what it means to say something causes something. I just sort of took it for granted. Only recently have I sort of questioned what is causation. And there turns out there's a lot of definitions, some of them pretty philosophical, some of them very statistical, rigorous with multiple criteria. But the most compelling to me comes from Judea Pearl. And Judea Pearl has become something of a guru in causal inference and causal science. He spent his career trying to train computers how to think like humans. And his insight is that computers are very good at seeing the world as it is. They're very good at seeing if two things move together and how much and how strongly they move together. But the correlation or the cliche goes that correlation doesn't imply causation, right? That's not enough to establish cause. In order to understand causality, you have to be able to imagine the world as it isn't. And computers are not good at that. They can't imagine the world as it is. And as far as I know, they're not able to do that yet. Human brains do this so automatically that we take it for granted. We can very easily imagine a world without A, and so we can imagine that if there really is a causal relationship here, there should be no B. This is called a counterfactual. And if you're a lawyer, you use the words but for. So to say that A causes B is to say that but for A, we would not observe B. Or more precisely as a scientist, but for the change of blank in A, we would not observe a corresponding change of blank in B. And this gets to the crux of what medicine is, or what it's supposed to be, right? We think there are things that are variables that are diseases, and they're diseases because we think they cause undesirable things. We think that but for these diseases, we would not observe these undesirable things. So we're imagining a world without disease when we say that, and we think it would be a better world than the one we're in. And medicine is all about trying to get there. How do we get there? By altering the variable disease with interventions. That pushes us to that better counterfactual world. That's the whole idea. Here's the rub, though. The ultimate proof of this arrow, the truth of it, whether you know that this arrow really is there and how strong it is, depends on the strength of this one. Okay? So if you can't shake this variable to view a corresponding change in this one, you don't really know that this arrow is there. And you have to have this arrow to even shake this variable. And this gets at sort of the existential crisis in sleep medicine, is that we think sleep apnea, obstructive sleep apnea, OSA, causes undesirable things. There's good circumstantial evidence for that. We think that but for sleep apnea, we wouldn't see these undesirable things, and we think the world would be better without OSA. The problem is we've tried to get there through CPAP, and we just frankly haven't done a very good job. This arrow has never been very strong, and that leaves this arrow in doubt. We don't really know if OSA truly is causing these poor outcomes. It's enough to leave a young sleep doctor up at night wondering what I'm actually doing for the world. But I'm doing something. I'm comfortable with my position, and I'll tell you why. To understand, you have to go through the history a little bit. And this goes back to 1889. This is the first description I know of that describes what we would call today obstructive sleep apnea. This was a Dr. Richard Cotton, who was at the Clinical Society of London, and he described a case of a 37-year-old man with extreme drowsiness, used the term narcolepsy, which pretty much just meant extreme drowsiness at that time. But he said this 37-year-old man had been healthy until the age of 30, when he became rapidly stout and the drowsiness first came on. The president of this society points out that in 1836, Charles Dickens wrote the posthumous papers of the Pickwick Club and described this boy named Joe who had a lot of extra weight and just sat around sleeping all day. So the connection of having some extra weight and sleepiness goes back even further than this. But what's interesting about this description is that Dr. Katana also describes this periodic upper airway obstruction. He says that during sound sleep, a convulsive closure of the glottis occurred, during which entrance or exit of air was entirely suspended, and violent inspiratory and expiratory efforts were made. Respiration was suspended for a minute or even longer, and the most marked cyanosis occurred. At length, the spasm yielded, respiration was reestablished, and the cyanosis disappeared. So what is this? This is obstructive sleep apnea. That's what it is. It is periodic obstruction of the upper airway that is temporary and occurs during sleep. Okay? So this, to my knowledge, is the first time that this cluster of things is described. Sleepiness, having extra weight, and having these obstructive respiratory events in sleep. The doctors at this session even imply a causal arrow in that they say they have patients who have extra weight, and they've observed that when those patients lose the weight, they get less sleepy, that but for the extra weight, they wouldn't be sleepy. So already we have this causal arrow. You don't get a formalization of this sort of description until about 60 years later when Burwell publishes a description of the Pickwickian syndrome, what today we call obesity hypoventilation syndrome. And this first description doesn't describe the apneas so much as just having extra weight, being sleepy, and having respiratory failure. So you don't get any more causal arrows yet. You have to wait until the 1970s when a group in Italy, in Bologna, bypasses these upper airway obstructions in sleep by just doing tracheostomy. Okay, so there's no more obstruction, no gas exchange disturbances. So you've treated the OSA, and they observed that this treated the sleepiness, that but for OSA, you would not observe sleepiness. 1981, Colin Sullivan describes continuous positive airway pressure, CPAP therapy, shows that that can treat these obstructive respiratory events, and the patients become less sleepy. And in that same year, Fujita describes the first uvulopalatopharyngoplasties, UPPs, which are a surgical technique to cut out extra tissue in the upper airway, also bypassing apneas, also treating sleepiness. So with a little bit of editing, this is essentially representative of the modern treatment of sleep apnea. Okay, we know now that Pickwickian syndrome, obesity hypoventilation syndrome is not equivalent to obstructive sleep apnea. They are related, but there are a lot of patients who have sleep apnea who are not Pickwickian. However, we also know that by losing weight, if you have extra weight in sleep apnea, you can relieve some of the apneas, maybe all of the apneas, and that can improve your sleepiness. So at least part of this causal arrow is through this effect. All right. We don't really do tracheostomies anymore. That would be considered particularly aggressive for sleep apnea. So I'm going to replace this with mandibular advancement therapy, also called oral appliances, dental appliances. These are splints custom made by a dentist. You wear them when you're sleeping. They give you a little bit of underjet, and by pulling the jaw forward like that, because the tongue is connected to the jaw in front, pulls the tongue forward, open things up. So altogether, these therapies up here represent essentially the modern armamentarium of the sleep doctor in treating obstructive sleep apnea. And for reasons that I hope will become clear later, I'm going to call these passive upper airway therapies. This is what I use day to day in the clinic. And there's a certain satisfaction in it because I know, as well as I know anything, that sleep apnea really does cause sleepiness, and that these passive upper airway therapies are an effective treatment for sleep apnea. So I can rest assured that I'm making the world a better place, or at least a less sleepy one. And that's not trivial. It's not the hard outcomes we usually think of, but patients require being awake in order to function during the day. And we all want our Uber drivers and our MTA operators to be awake, to not be sleepy. So I can rest a little easier, sleep a little easier. In any case, everybody in this room, I think, probably suspects that there is some connection between sleep apnea and undesirable things other than sleepiness. And why would that be? How can you even have sleep apnea if you're not sleepy? Well, that gets to the definition of what OSA even is, and that has its own parallel history going back to the 1970s and visible in the modern polysomnography. The apparatus I'm wearing on my head here includes this plastic thing. This is an oronasal thermistor. It can just detect changes in temperature. So breathe out, gets warmer, breathe in, gets colder. It's purely qualitative. It can only tell whether you're breathing or not. So for example, this is the thermistor signal, or at least a depiction of it. Inspiration is up, breathe in, breathe out, breathe in, breathe out. Nice breathing here. There's a long pause here, and as long as this is at least 10 seconds in length, we call this an apnea. And Guilleminault in the 1970s decided, a little bit arbitrarily, but had to pick some number, said that if you sleep and have 30 apneas or more during sleep, then you have sleep apnea. Quickly realized, however, that not everybody sleeps the same amount. People sleep for different lengths. So decided to make an index of this by taking the total number of apneas and dividing it by the total sleep time. What would be an elevation in that? Well, if you had 30 apneas and you slept for 6 hours, an apnea index of 5 seems reasonable. So two numbers chosen a bit arbitrarily, but 5 and 30 have stuck with sleep science through the modern day. I'm also wearing a nasal cannula here, and that's a later addition. And my mentors were instrumental in sort of encouraging the community to adopt this, and for good reason. It's because there's not just an absence of breathing that occurs during sleep. There can be periods of not enough breathing, okay? So a thermistor, as I said, is purely qualitative. It can only see whether you're breathing or not. It can't tell whether your breaths are big or little. A nasal cannula can do that. And if you have a lot of little breaths in a row, we call that a hypopnea. So for the first time in the 1980s, the apnea-hypopnea index appears in the literature, and that's take the number of apneas plus the number of hypopneas divided by the total sleep time. You get your AHI. Terry Young publishes her seminal study in NEJM in 1993. Says if you have an AHI over 5 and you're sleepy, 2% of women and 4% of men have the disorder of sleep apnea, so it's common. In the meantime, the American Academy of Sleep Medicine has sort of ignored all this rigorous quantification, and without a threshold, without a specific number, just says that if you have frequent episodes of obstructive breathing and sleepiness, then you have sleep apnea. And in the meantime, people are asking, what does it mean to not breathe enough? Like, whose hypopnea are we talking about here? Different people see hypopneas in different places. It's subjective. So the decision is made to define it by some immediate consequence. Out on my selfie hand here, I'm wearing a pulse oximeter. So if there's what look like a bunch of small breaths in a row, and subsequent to that, there looks like there's a drop in saturation, call that a hypopnea. You could also use if there's interruptions in sleep. So on electroencephalography, on EEG, you can see if sleep is there, if there's a bunch of small breaths, and then a brief awakening occurs, called an arousal. And in that case, if there's an arousal following a bunch of small breaths, that's a hypopnea. This leads to the Chicago criteria in 1999, which evolves into the AHI-3A. And in 2007, we get the first AHI 4% and AHI 3A description together, which has come to us to the present day, persisted to the present day. What's the AHI 4%? You just take the total number of apneas plus hypopneas with 4% desaturation divided by total sleep time. AHI 3A, number of apneas plus hypopneas divided by 3% desaturation or arousal. Divide that by total sleep time. I know this seems confusing, but don't worry, I'll tell you which one of these is right. Actually, I won't, I can't. Nobody knows. This is controversial even among sleep doctors. We still don't know exactly what the correct definition of sleep apnea is. For my part, I'll say that clinically, I think the top definition is the most correct. If I have a patient in front of me who I think has frequent obstructed breathing events in sleep and they are sleepy, they have sleep apnea, or at least they have enough to justify a trial of passive upper airway therapy to see if it relieves their sleepiness. All the rest of this stuff, these metrics, become academic. Of course, in research, academic is exactly what we're looking for, right? So each of these metrics has at one time or another been connected to undesirable things other than sleepiness. And there's enough circumstantial evidence that we are tempted to say that but for OSA, this patient in front of us would not be at increased risk of these undesirable things. To give you a seminal example, Terry Young again publishes this paper in 2008. It describes the Wisconsin sleep cohort. This was a community-based study that looked at the association of OSA with that most undesirable of things, death. What they did is they used the AHI 4%, and as kind of an aside here, historically, the AHI 4% has been used most of the time in most of our studies to connect to the bad things. So I'd like to be able to tell you that if you're trying to assess the risk of somebody having poor outcomes because of sleep apnea, you should use the AHI 4%. That's probably almost true, but there are enough caveats that I'm not comfortable saying it. The AHI 3A may be correct for some patients. In any case, Wisconsin sleep cohort used the AHI 4%. What they did is they recruited about 1,500 adults by simple random sample from Wisconsin state agencies, had all of them undergo an in-lab polysomnogram, and they followed them for about 20 years looking for deaths by the Social Security Death Index. What they find? As your AHI goes up, your risk of death goes up. Your survival drops over time. Okay. So remember I said 5 and 30, 5 no OSA, 30, 5 no OSA, 30 severe OSA. That's stuck with us. And then we put a 15 there. Why? Because it's between 0 and 30. It's that arbitrary. So these are the severity metrics we still use. 5 to 15 is mild, 15 to 30 is moderate, and over 30 severe. They were pretty arbitrary when they were chosen, but at least this study is showing that maybe there's some empiric justification for it. It does appear that if you have severe obstructive sleep apnea, your risk of death is far increased over moderate or mild. However, this is an unadjusted analysis, and that deserves its own aside because it gets, again, at what causality is. To control for, to adjust for something. Well, when we have any causal question between two variables, we have to acknowledge that there are a lot more variables in the world, an infinite number in theory. But we can imagine a third that might be a cause of A and also a cause of B. Such a variable would be said to confound the relationship between A to B. It would be called a confounder. And confounders are the bane of studying causation between variables, especially in observational studies. Smoking is the classic one in the relationship of exercise to lifespan. If you look at exercise and lifespan alone, it looks like the more you exercise, the longer you live. The data's made up, of course, but just to illustrate the point, if you look at smokers alone or non-smokers alone, or you adjust your analysis to stratify by smoking, you see that this relationship disappears. So smoking confounds the relationship of exercise to lifespan. Sleep apnea has a lot of confounders. Age is probably the easiest one to understand. As your age goes up, your risk for sleep apnea goes up, and as age goes up, of course, your risk for undesirable outcomes goes up. So age confounds the relationship of sleep apnea to poor outcomes. It's not the only thing. Age, sex, elevated weights, smoking, alcohol use, these have all been demonstrated to confound this relationship. On the other hand, there are things that are not confounders. There are variables that have no relationship to this, but then there are variables that have almost the opposite in a way. Imagine M. A is a cause of M is a cause of B. We would say that M mediates the relationship of A to B, that it's a mediator, or maybe more intuitively, it's a mechanism through which A causes B. Just like confounders, there are a lot of potential mediators in the path from OSA to poor outcomes. Hypertension is probably the most classic. There's good evidence that having untreated sleep apnea elevates your blood pressure. And of course, we know that chronically elevated blood pressure leads to poor outcomes in the long term. So hypertension is a mechanism through which sleep apnea causes undesirable things, if it does indeed cause them. It's not alone. There's a lot of stuff that sleep apnea does. It has a lot of immediate and long-term consequences. So hypertension, just dysregulation of the autonomic nervous system, gas exchange disturbances, and sleep disruption itself, as well as inflammation. This is sort of the newer being studied one. All these things potentially are mechanistic on the pathway of sleep apnea to poor outcomes. The gist of it is that you want to control for the confounders, but you don't want to control for the mediators if you're really trying to study this causal arrow. To put it precisely, when investigating the total effect of sleep apnea on some undesirable thing or things, you should adjust for all the known confounders, but not for any of the mediators. So back to the Wisconsin sleep cohort, what did they adjust for here? Age, sex, BMI, what do they find? A threefold increased risk of death if you have severe obstructive sleep apnea. Also increased risk in mild and moderate, but it doesn't achieve statistical significance. They didn't control in this analysis for hypertension, coronary artery disease, cardiovascular disease in general, heart failure, MI, or stroke, which I think is appropriate because each of these things we think can be contributed to by OSA. Hypertension I've discussed, maybe plaque instability in coronary artery disease, the hypoxemia in CV disease, introthoracic pressure changes and heart failure. So all of these things plausibly OSA can contribute to, and clearly all of these things can contribute to death. So they're reasonably viewed as mediators, as mechanisms. However, they did adjust for these in another analysis and showed that the risk of severe sleep apnea and death is still threefold increased. So what does that imply? That maybe there's an unmeasured mechanism, an unknown unmeasured mechanism by which sleep apnea increases the risk of death beyond these things. Okay, so this to me is pretty good circumstantial evidence of a connection. But humbly, you have to acknowledge that all of this could be blown up by unknown and unmeasured confounders. Still, it's enough to justify seeing if we can shake the variable of OSA to reduce bad things in the long term. This study from 2005 was an observational study of the effect of CPAP on cardiovascular events. And they took 1,500 men in this case with snoring, referred to sleep clinic. They said, you have sleep apnea or you don't have sleep apnea. If you had sleep apnea, they said, go on CPAP. But patients were given the choice of whether to go on CPAP or not. So some did, some didn't. They followed them over 10 years and they were looking for cardiovascular events. What they find? That both fatal and non-fatal cardiovascular events were increased in those with severe obstructive sleep apnea who chose not to go on CPAP. For those who chose to go on CPAP, their rate of bad things was about the same as healthy controls. So the argument is that, of course, that severe sleep apnea increases your risk of fatal events. In the unadjusted analysis, the risk is fourfold increase. If you adjust, it drops to threefold increased. Maybe even higher, because I'd argue they adjusted for a couple mediators in here maybe. But the principle is that you can use CPAP to reduce your severe sleep apnea and therefore reduce your risk of fatal cardiovascular events. But what's the problem? The patients chose to go on CPAP. You let them decide whether they go on CPAP or not. And that is always going to introduce unknown, unmeasured confounders. That there may just be something about people who chose to go on CPAP that also reduces their risk of fatal cardiovascular events. So this whole pathway is left in doubt by those unmeasured confounders. You can control for the things you know, but you're always going to have stuff you don't know. And this reflects sort of the headache of trying to study the causal pathway of sleep apnea. To make it even more complicated, these unmeasured things probably contribute to sleep apnea itself, confounding this relationship as well as this relationship. And they probably interact in some way with what we know and can measure. So this is becoming very tangled and complicated and hard to think about. And this is a reason why, I think, one of the big reasons why we like randomized controlled trials so much. Because instead of letting patients decide whether they're treated or not, you let randomness decide. And if you let randomness decide instead of the patients, you, in theory, get rid of all these confounders. And you're left with a nice causal pathway from a coin to CPAP to treating sleep apnea to really testing this causal arrow. So let's talk about one of the big randomized controlled trials of CPAP for treatment of obstructive sleep apnea. I'm not going to talk about all of them. This is SAVE. This was published in NEJM in 2016. It's the biggest study that I'm aware of looking at treatment of sleep apnea. And this was in about 3,000 patients. They had established cardiovascular disease. They were looking for secondary prevention, whether they could prevent further cardiovascular events. They excluded sleepy people. And that's a common theme in randomized trials of sleep apnea therapies because we know we can treat sleepiness. Why would you deprive patients of an effective treatment? So we exclude the sleepy patients. About 2,700 get randomized, 1,400 to each group. They have mean follow-up of about 4 years, very good retention. And at the end of this 4-year period, they compare a composite outcome of cardiovascular death and major cardiovascular events. And what do they find? Virtually no difference. Lines are practically overlapping. So what is going on here? Well, if you look at the adherence, adherence is a complicated concept. A lot of randomized controlled trials use pills, which you only have to take once, one time a day. CPAP, you have to put on and leave on for your entire sleep period. And if you estimate that people sleep for 6 to 9 hours per night, even in the first week of treatment, those assigned CPAP were giving themselves a dose of untreated sleep apnea. And as the trial went on, a greater and greater dose of untreated sleep apnea, until at the end, you were arguably comparing people with untreated sleep apnea to people with untreated sleep apnea. So, as I said, the ultimate proof of this arrow depends on the strength of this one, and this one just wasn't very strong. And this is a common theme in trials. It's really hard to get patients to adhere to therapy, so we don't know that we're actually testing two different groups of patients. You could just look at the adherent patients. That would re-strengthen this arrow, and you'd be in a better place to test the strength of this one. But the problem with doing that, of course, is that you break randomization and all the confounders come back, and it's like you're not even doing a randomized control trial. It's another observational study. There have been fancy ways to deal with this, and the SAFE trial used or reported a post hoc analysis where they used propensity score matching. They were trying to match healthy adherers, people who were assigned CPAP, to people who would have adhered had they been assigned CPAP using baseline factors. So it's a simulated randomized controlled trial, at least in principle. You take apples and compare them to apples, people who did adhere to those who would have adhered. In principle, you can control for the measured confounders that way. And if you believe this, that you're really capturing the same patients, then you're also adjusting for those unknown things by adjusting for the known things because of this interaction. I think some healthy skepticism is warranted here, but that's the logic. So what they find, they had 561 who were assigned CPAP and were adherent, 561 matches who were assigned usual care, but in theory, would have been adherent had they been assigned CPAP. In the composite outcome, there was no statistically significant difference, though you lean towards benefit a little bit. And then there's borderline significant benefit for the prevention of stroke and significant benefit for a composite outcome of stroke plus TIA. The optimist in me wants to believe this. The skeptic in me is pretty unsure. So just to summarize, all the major trials here, they all sort of have the same themes, the same problems. Apples was in 2012. It was looking to see if we could improve cognitive outcomes, negative trial. Barbet is the only major trial for primary cardiovascular prevention, so patients who don't have established cardiovascular disease that I'm aware of, also a negative trial. And there have been 3 trials for secondary cardiovascular prevention, all of them negative. They were summarized recently in this meta-analysis, which you can see that if you take all the individual patient data from all the patients in all 3 of these trials, no significant difference. However, if you look at the people who are adherent, they look like they do better, but confounding. So, back here, wondering if we're not treating a sleepy patient, what are we actually doing? Are we accomplishing anything? So what to do? We could give up. We could say that, we treat sleepy people, and like I said, that's not trivial. That's important. But I'm not comfortable with it, and I'm not comfortable with it because I'm pretty compelled by the circumstantial evidence. I know that there are reasons that this causal arrow might not exist, even though it seems to, that it could all be unmeasured confounders, but we don't know that yet, and I'm not comfortable concluding that yet. So if we're not going to give up, I see 3 options. We could encourage adherence or prescribe treatments that patients will actually use. And that is the vast majority, the bulk of my practice when treating patients with obstructive sleep apnea. On the research front, we're reconsidering the disease, and we're also reconsidering the treatments. Are there things other than these passive upper airway therapies that we should be considering that patients will actually use? So encouraging adherence, like I said, this is a lot of my practice, and I'll tell you a common story. I see a lot of patients who've been diagnosed with sleep apnea in the past, and they say they tried CPAP for about a month, couldn't get used to it, so they sent it back. And if you dig a little bit deeper, what usually happened is the order went to a durable medical equipment company. The durable medical equipment company kind of like arrived and threw a full face mask at them, and they tried to wear this thing that covered their entire face, made them look like Darth Vader, made it difficult to even talk to anybody. And they hated it and couldn't get used to it, and so they sent it back and think like, well, CPAP just doesn't work for me. I try to discourage this, or at least encourage patients with the knowledge that there are a lot of different interfaces. This has exploded. The field has exploded with all the different options there are available for what you can wear on your face. And some of this stuff is pretty low profile. And my approach is always like, start with the lowest profile you can get away with. Don't throw Darth Vader at the patients because they're going to get discouraged. Sometimes some patients have to use this, but most people can get away with something else. And I say to the patients, like, look, people's response to a mask is as idiosyncratic as people's faces are different. So the first mask you use, you're probably not going to like. Don't give up on it. We'll find something. There's a whole literature on adherence. There's a lot of different approaches. I could give a whole talk on it, but I thought this point is worth mentioning. Okay, second point, and this is where there's probably arguably even more art than science. There's science to sort of direct us at saying this patient should get this therapy, this patient should get this therapy, but it's not very strong. And a lot of it when you're in the room with the patient is sort of like saying, do you have friends with CPAP? What do they think? Do you have family with CPAP? Do you want this? Do you want that? But my general approach is something like, if you have a middle-aged male patient who is sleepy, who's somewhat overweight, CPAP's probably a good choice. He's probably going to use it, find it helpful, probably going to relieve sleepiness. On the other hand, if you have a young, thin woman with sleep apnea and she's having a lot of insomnia, disrupted sleep, difficult to get back to sleep, CPAP's probably not a good idea, and I'll direct her more towards the dental appliances. Okay. In this theme, we are researching methods to assign patients the appropriate therapies. Look at this data here. This is also, observational circumstantial evidence, but in patients who have sleep apnea, they have an earlier onset of mild cognitive impairment than patients who do not have sleep apnea. The ones who are on CPAP, however, appear to have the same onset as those who don't have any sleep apnea at all. So this is an arrow worth testing. And you can test that with passive upper airway therapy, of course. But the way Andrew Varga here at Sinai is doing it, in collaboration with Katie Stone at California Pacific and Ricardo Osorio at NYU, is through a kind of complex algorithm. What they're doing is they're assigning patients in this essential trial to look at the effects of cognitive outcomes. They're assigning patients an initial therapy, then pretty quickly testing whether the patients are adherent to that therapy and whether it's effective. And if it's either not effective or they're not adherent, they immediately switch them to an alternative modality. So by the end of the trial, you hope that everybody's on a therapy that's effective and they're actually using it. Strengthen this arrow as much as possible to really test this one. Like I said, we're reconsidering the disease. And remember I said this top definition, to me at least clinically, I think is the strongest one. There's evidence now that it might be the strongest one. In cluster analyses that have been done at the University of Pennsylvania, they've shown that people who are sleepy with sleep apnea, who are really sleepy, those are the people that bad things happen to in the long run. They have a worse onset of, for example, cardiovascular disease here than patients with minimal symptoms or just disrupted sleep. So maybe sleep apnea should be defined by sleepiness because that is the disease. That's the thing that leads to the undesirable things in the long term. And so we should test whether we can make an alteration in this. That's the controversial idea, is to stop excluding sleepy people from randomized controlled trials. Finally, maybe we should reconsider these metrics, even if we're not going to define things solely by symptoms. The AHI is clumsy. It includes all different kinds of respiratory events. So a partial airway occlusion for 11 seconds gets a point, just as a total airway occlusion for 90 seconds gets a point, when these are clearly not the same thing. If you desat to 92%, that's treated the same by the AHI as desatting to 75%. So it's capturing a lot of heterogeneity without showing the heterogeneity. So the field in general is trying to move beyond the AHI. And I'll give you an example. Say you have two patients, one up here, one down here. These are their pulse oximetry signals. They each have 3 respiratory events, and they desat with every respiratory event. By the AHI, these patients are equivalent, okay? But they're clearly not actually equivalent. This patient has a higher hypoxic burden. They desat to a greater extent than this patient. And Ali Azarbarzin at Harvard has figured out an algorithmic way to quantify this hypoxic burden, and he's shown that the people with the highest hypoxic burdens are the ones that the bad things happen to. So maybe that should be part of the disease definition. Similarly, you can look at the size of breaths on the nasal cannula, and my mentors and I, we remain a little bit obsessed with the nasal cannula, but this has been our idea, is that if you have 2 patients, for example, one has 2 respiratory events with hypopneas that are kind of short, and one has 2 long apneas that are really deep, they're treated the same by the AHI, okay? But clearly they're not the same. This patient has a higher ventilatory burden, and Ankit Parekh here at Sinai has figured out an algorithmic way to quantify the ventilatory burden and shown that it is connected to poor outcomes in the long term.
Oh God, I feel
Along with
bad
David
for you.
Rappaport, Dr. Parekh has come up with this idea that's still in development, that we should be looking at a multidimensional assessment that quantifies multiple parts, multiple physiologic disturbances that occur in the setting of obstructive respiratory events, the ventilatory burden, the hypoxic burden, and how disrupted sleep is. If you can bring all these together and quantify them, maybe you provide a better definition of disease. Okay. Finally, reconsidering the treatment. Like I said, I call these passive upper airway therapies. This represents the modern armamentarium of the sleep doctor when treating sleep apnea. I didn't really know about any of these except CPAP up through the, middle of my pulmonary fellowship. So I hope I can be forgiven for having kind of a simplistic model of how sleep apnea is, or how it works, what it is. What I thought was that in people with some sort of anatomical upper airway problem, usually extra weight, that because they have this anatomical problem, when they go to sleep, their airway collapses. And because they're not breathing well, that disrupts their sleep and they wake up and they sort of like go through this cycle over and over again during the night. So of course they need an anatomic therapy, a passive upper airway therapy, just to treat that anatomy, to keep the upper airway open. That's not totally inaccurate, but it's got a lot missing. And if this is your model, the model you carry around in your head for obstructive sleep apnea, I want to disabuse you of that. And I use that word very intentionally because it's incorrect, but I'm going to tell you the more current incorrect thinking that hopefully is less incorrect. We have a model of sleep apnea that I'm always reminded of by the phrase, people don't snore when they're awake. Okay, it sounds trite, but it's important because with any anatomic disease, if there's a structural problem, it tends to be there all the time. Sleep apnea isn't like that. People only have it when they're asleep. There's no structural issue with the upper airway. So what's going on? Well, the upper airway is under neurological control. So like I said, no problem with the upper airway. I'm a pulmonologist. I always want to say it's not the lungs or the airway. So turf to neurology. This is, I would argue, in a lot of ways, a neurological disease. And we know that in part because we do these CPAP drop studies. These are studies where you bring patients into the lab, you know they have sleep apnea, you have them on CPAP, sleeping nicely, then you turn CPAP off and watch what happens. Okay, so for example, let's say you have 2 patients. They're both sleeping steadily, they're on CPAP, their breathing looks really good, and then suddenly we turn the CPAP off. Okay, patient on the top, their airway collapses a little bit, and so they have little breaths. Patient on the bottom, airway completely collapses, so they don't breathe at all. What happens when you're on CPAP is that your upper airway relaxes a lot because you don't need it to have a lot of tone, right? You don't need the neurological activity to keep breathing, so it's very relaxed. And when you turn CPAP off, you can see what happens in the setting of that relaxation. So this is the passive upper airway. And the point is that some people have a very collapsible passive upper airway, like down here. Some people have a less collapsible upper airway. This is essentially, the classic pathophysiology of sleep apnea. And we still think this is probably the most important factor that leads to sleep apnea. And it's what we treat with passive upper airway therapies. But it's not alone. Imagine again, two different patients this time. You turn CPAP off and they don't breathe at all. We would say that both of them have highly collapsible upper airways. They're not breathing. But if they're not breathing, their CO2 is rising. If their CO2 is rising, the thing that happens is some patients will send a signal to their upper airway to open up, and other patients won't. We don't really know why, but that seems to be what happens. So some patients will correct for this by opening their upper airway, and they'll start breathing again. This is called compensation. Some patients have good compensation and some patients don't. And this is thought to also contribute to obstructive sleep apnea. And we're currently targeting this with drugs. We have animal data and early trials that show that combination noradrenergics and antimuscarinics can improve the AHI. For example, this study from 2019 in 20 patients, they use atomoxetine, a noradrenergic, plus oxybutynin, a antimuscarinic, to show that you can decrease the AHI. More recent trial used a combination of atomoxetine plus eroxybutynin. More patients, I think 42 in this case, also showed a decrease in the AHI. That's not all. Let's say you have two different patients again, you turn CPAP off, and they both, they don't have so much collapsibility here, but this patient on the top really doesn't like this. Okay, their brain immediately reacts to this reduction in breathing, while the patient on the bottom doesn't. Okay, so this patient immediately wakes up. Okay, so they've interrupted sleep. They've gotten rid of the obstruction, but now they're awake. Their sleep is disrupted. This patient on the bottom, however, allows those compensatory mechanisms to take place so their upper airway opens and they don't interrupt sleep. Patient on the top is said to have a low arousal threshold. Their sleep is brittle, easily disrupted by respiratory events. And this is also thought to contribute to obstructive sleep apnea. And there's some data, not very strong, but some data showing that if we use hypnotics on these patients, sleeping pills like azopiclone or Lunesta, we can improve the AHI. Interestingly, Andrei Zinchuk at Yale has some data showing that maybe these patients with this low arousal threshold are exactly the patients who shouldn't get CPAP. So if you have thin people who have a low arousal threshold, they're really bad at using their CPAP consistently. Remember that young thin woman I talked about with the interrupted sleep who you probably shouldn't put on CPAP? This is empiric evidence of that. Okay, the last mechanism, the last contributor to sleep apnea is probably the hardest to describe. And it's not really about what happens when you turn CPAP off. It's about what happens when you turn it back on. So let's say you have these two patients, you've turned CPAP off, their breaths are small, and then you turn it back on in both of them. One patient, their breathing pretty much immediately returns to where it was before you turn the CPAP off. This other patient, on the other hand, has some big breaths, then they decrease to small breaths, then back to big breaths. And this can propagate even further. So they're doing this oscillation thing where it's like, this was the initial disturbance, but now they're having these hypopneas following the initial disturbance. This is due to instability of breathing control. It's quantified by loop gain. And if it's normal, you have stable breathing. If it's high, you have unstable breathing, and events beget events, okay? I like to think of it as like a cat flicking a doorstop. So the cat's paw is the CPAP drop initially, right? And some people, when you flick the doorstop, they'll immediately return to their baseline. They'll go back to breathing stability. Other people will oscillate a lot. Some people are very springy, some people not springy at all. So all this put together is how we think sleep apnea happens. There's some data showing that we can treat high loop gain with drugs and maybe with oxygen. Acetazolamide is the archetype. If you have patients with high loop gain, you can decrease their AHI using acetazolamide. Okay, so altogether, this has been called the four-trait model. Trait is probably not a great word because it implies like something immutable, and we're not really sure that that's true. Four mechanism model, four endotype model. I guess I prefer four mechanism pathophysiologic model of sleep apnea, but that didn't fit very well on the slide. So if you take four trait model away, that's good enough. The nice thing about this is maybe we don't need CPAP drop studies to quantify these traits anymore, because a group at Harvard had this rather ingenious idea that you could just take a routine PSG, a routine sleep study, and use the patient's own native respiratory events in lieu of the CPAP drops. And they've created an algorithm that can sort of spit out these 4 traits to you, and these, in theory, could guide treatment. So, to summarize, sleep apnea causes sleepiness. We know that about as well as we know anything, and we know that the passive upper airway therapies we have, like CPAP and oral appliance therapy, are effective. What's in doubt is whether sleep apnea causes things other than sleepiness that are bad outcomes, undesirable. And it's partly in doubt because we've never done a very good job at removing the sleep apnea from people who are not sleepy. So what's my current clinical approach? I'm honest about this. If I have somebody in front of me, a patient in front of me who has severe sleep apnea, who is not sleepy, I sort of say, look, the data shows that people with severe sleep apnea in the long run seem to have an increased risk of bad things. We've never proven that we can change that, but people who are adherent to therapy do better. So you be one of the adherent ones. We're rethinking the definition of obstructive sleep apnea, whether that should include sleepiness, whether we define it by symptoms, whether we define it by how much gas exchange disturbance there is, how small the breaths are, or how disrupted sleep is. We're trying to quantify all these things together, and it's a developing field. The thing to take away is that sleep apnea is not a purely anatomical disease. People don't snore when they're awake. Finally, in the future, you may see these traits, these mechanisms appear on sleep studies, and they may be able to help us choose therapies other than passive upper airway therapies. So just want to thank a few people, my mentors, my big brother semi-mentors here at Sinai, a lot of people in pulmonary critical care sleep division leadership who have believed in me and invested in me. I thank them. And of course, everybody at the 26th Street Research Lab. And I'm happy to take any questions.
Great talk, Tom.
Thank you.
Clearly, you've invested a lot of time, just purely based on the animations. The reading aside is different. And it's great to see people take this platform as seriously as you have. So thank you for making our time worthwhile. I guess my question really revolves around the concept of sleepiness, I think,
Yeah.
which is really, it's important, right? And I know Ankit is doing some work in that space, and you as a clinician, I'm wondering sort of what are your thoughts about sleepiness as it pertains to sleep apnea, and where do you think maybe the field could be going, or where do you think we should be, how do you think we should be thinking about sleepiness in obstructive sleep apnea?
Yeah, I think what you're getting at, Dr. Shah, kind of goes to, it's really hard to quantify sleepiness or to know what sleepiness is. It's a subjective measurement, right? The best I have is that people tell me they're sleepy during the day. We get these Epworth sleepiness scale scores that we know are not very good. We still look at them. Let me see if I can go back to that study by the University of Pennsylvania group. One of the problems with looking at just excessively sleepy patients is that the definition of excessively sleepy has not been operationalized, right? So I showed you this data. This is a complicated thing to measure. In these cluster analyses, they're using lots of different variables to say who is excessively sleepy and who is not. And I actually wrote an editorial that sort of criticized this to say, like, look, this is a great finding, but how are you actually going to bring this into the clinic? So at the end of my answer, it's like, I agree with you, and I don't know the answer to it. The best I have is that patients tell me they're sleepy, and I believe them. As far as what to do going forward, it would be nice if we could do MSLTs on everybody, but in the absence of that, the University of Pennsylvania group is doing a lot of work to try to actually operationalize this for the clinic. Oh, sorry.
Where do you think your research is going to try to address these gaps? What would you like?
Yeah, so I have some preliminary data showing that patients with heart failure have sort of systematically very low arousal thresholds. So if you test arousal threshold in people with sleep apnea, you get a distribution that looks like this. People with heart failure look like this. They're very tightly in a low arousal threshold. So if you believe that four-trait model, arousal threshold is the thing to go after. The problem is that hypnotics are what we use to go after arousal threshold, and hypnotics are not well tolerated by people with heart failure. So Nancy Redeker up at Yale has done work showing that there are functional benefits to cognitive behavioral therapy for insomnia for people with heart failure, as well as lengthening their sleep time. At the same time, there have been trials showing that people who have comorbid insomnia and sleep apnea, if you treat them with cognitive behavioral therapy for insomnia, their sleep apnea gets better. So my thought is that we can use CBTI in heart failure patients to try to improve their sleep apnea, even if they don't complain of insomnia per se. And that's where I hope to be going in the short run. In the long run, in general, I'm trying to see how cardiopulmonary diseases influence these traits, these mechanisms, and whether having a comorbidity predicts that you're going to have a certain disturbance in one of these mechanisms that should be targeted. Sure.
Tom, can you comment on the Inspire
Yeah.
as a treatment? There is a lot of direct-to-consumer advertising, so patients ask.
Yeah, so if you haven't seen them, there are these studies now, or these commercials where these patients are sort of like sitting in a support group, and for some reason they're all wearing their CPAP masks. I guess it's like a CPAP support group. And then like one guy shows up and he says like, I don't need a mask, I just use a button. And so there are patients coming into sleep clinics now who are saying like, oh, I want that button. And they don't understand what they're actually asking for. It's Inspire therapy or hypoglossal nerve stimulation. And I meant no disrespect to the surgeons who treat sleep apnea, but I sort of grouped all the surgery together and I throw Inspire therapy into that bucket of surgical therapies for sleep apnea. What it is it's an implant. So they put a pacemaker sort of battery in your chest and then run a wire down to your diaphragm. And they can detect when your diaphragm is active. So they have a second wire that goes under the skin of the neck up to the hypoglossal nerve, detects when you're trying to breathe in and makes you stick your tongue out when you're sleeping. And you can see this in the OR. When they first put the thing in, they test it and the patient's, anesthetized, they go like that. It has a very strange side effect that I bet is pathognomonic, is irritation to the bottom of the tongue from repeatedly being stuck out over the teeth overnight. In any case, it's a good therapy for select patients, I think. I have patients who can't tolerate CPAP and are relatively skinny, and those are exactly the type of patients who I refer to Dr. Fredlin here at Sinai for potential Inspire therapy. But it's not as simple as like somebody throws a button at you and you don't have sleep apnea anymore. Yeah.
Like operationalize some of these definitions and like change your practice.
Yeah, so I mean, you're getting at my research interest, right? I'm thinking you can use cognitive behavioral therapy for insomnia to actually treat sleep apnea, at least in select patients. So the reason I went down that road in the first place was the observation that if you have a lot of stage N1 sleep, which is like the transitional light sleep, you have more sleep apnea because your breathing is just more unstable. Okay, so if you have stage N3 sleep, which is deep sleep, you have less sleep apnea. And so the chicken or egg thing that happens is that you don't know if your sleep is unstable and that's driving your sleep apnea, or if your sleep apnea is interrupting your sleep and making your sleep unstable. So either makes sense, right? You could try to treat the sleep apnea primarily and make the sleep more stable, or you could go after, as I think you're suggesting, improving sleep stability, and that would treat the sleep apnea. And that's sort of something I'm interested in as kind of a counterfactual to where the rest of the field has been. Yeah, I do think that if somebody is, well, they say caffeine is a very effective treatment for sleep apnea, but obviously if you're drinking a lot of caffeine late in the day, it's going to make your sleep unstable, and that might actually give you worse sleep apnea late in the day. So yes, I think I've answered your question. Behavior, I think, matters, but we don't know yet.